My name is Tina. I'm one of the new geriatricians here at SHN, and today I'll be presenting on delirium. The second half of my talk is going to be on when to suspect rapidly progressive dementias. So delirium should be thought of as acute brain failure. It's the final result of the brain decompensating due to multiple mechanisms. So really, we should be thinking of it as acute kidney injury or acute heart failure. And delirium first appeared in DSM-3 in the 1990s. It is an acute onset confusional state that's characterized by fluctuations in attention, cognitive dysfunction, and an altered level of consciousness. And you can classify delirium into phenotypes based on the motor activity. So the minority of cases of delirium are hyperactive, and this makes up 25% of cases. People tend to have increased motor activity, and they're quite agitated. People who get hyperactive delirium tend to be males and younger, but the majority of cases of delirium are hypoactive. This makes up 75% of cases. Patients have decreased activity, speech, reduced speed, and alertness. And people who get hypoactive delirium tend to be more frail. So these people tend to have polypharmacy and more cognitive and functional impairment at baseline. People with hypoactive delirium tend to have worse outcomes, such as mortality, increased length of stay, more falls, more institutionalization, and a decreased quality of life. So some key figures in delirium are that only 12 to 35% of delirium cases are recognized. Over half of cases of delirium are not identified, probably because the majority of people have hypoactive delirium. And even though most episodes of delirium last a few days, some episodes can persist for weeks to months. In fact, 20% of people have symptoms of delirium at 6 months after their episode. So that's why when we see people in hospital for delirium and we book them for follow-up at the GAIN clinic, we do it 6 months after their delirious episode, so that features like inattention and altered LOC don't affect their cognitive test scores. Delirium is associated with mortality. The in-hospital mortality of delirium is 25 to 33%, which is double that of acute coronary syndrome, which is only 12%. Delirium is also associated with new institutionalization and dementia. Delirium is also quite expensive. The cost attributable to delirium is $50,000 to $60,000 per patient. So key point number one is that delirium should be treated as a medical emergency, and many cases of delirium are undetected since hypoactive delirium is more common, yet it's the one that's associated with worse outcomes. Recent literature has shown that delirium could actually be a modifiable risk factor for dementia. And that's because delirium's strongly associated with the new diagnosis of dementia and also with acceleration of an underlying dementia. The more episodes of delirium a person has and the greater severity of delirium that person has is associated with worse cognitive outcomes. The majority of patients, 67% of people, have substantial cognitive impairment a year after their episode of delirium. And they have worse cognitive impairment if that episode of delirium is associated with sedatives, hypoxia, and sepsis. And the cumulative incidence of dementia is 31% after 5 years of having delirium. So key point number two is that delirium may unmask an unrecognized dementia, or it can accelerate underlying neurodegeneration that causes a dementia. And actually preventing delirium could potentially reduce dementia risk. This table just shows the prevalence of delirium in different settings. So in nursing homes, the prevalence of delirium ranges from 3 to 38%. In the emerge among older patients, it's 15%. And then 1 in 4 people have delirium in the inpatient setting, post-stroke setting, after an elective surgery. The prevalence of delirium increases to 1 in 2 people after high-risk procedures, especially if it's an emergent surgery like hip fracture or cardiac surgery. When people get TAVIs, there's a lower incidence of delirium if the TAVI is done through a transfemoral approach, but other approaches of TAVI have a 21% prevalence of delirium. And then delirium, of course, is very common in the ICU, especially among mechanically vented people, where the prevalence is 50 to 80%. And delirium is quite prevalent in palliative care in those approaching end of life at 60 to 80%. So as you can see, delirium is quite prevalent across many settings. And who are people that are at risk of delirium? So these are non-modifiable risk factors. Things like having an advanced age, dementia, low education, a high amount of comorbidities, visual sensory impairment, malnourishment. These things all increase the risk of getting delirium. But these are modifiable risk factors that we can potentially change in hospital. So people who get physical restraints in hospital have the highest risk of getting delirium. People who get benzos, have Foley catheters, who don't get visits from their relatives, who are in intense pain, don't see sunlight, and stay and emerge for longer than 10 hours. These are all risk factors we can potentially modify. For example, instead of using physical restraints, if someone's trying to pull at their IVs or tubes, you can try using mittens. Foley catheters should always be reassessed for their indication. Families should be encouraged to visit. One study has actually shown that if you give people opioids for managing their pain, it's associated with less delirium than if they were just in severe pain. And then for no visible daylight, you can try moving people who are at risk of delirium closer to the window if they're in a 4-person room. So key point number 3 is to prevent delirium, you want to minimize restraints, minimize benzos, reassess Foleys, and address pain. And in order to diagnose delirium, you do have to meet all 5 of these criteria that are part of the DSM-5 criteria. You have to have a disturbance in attention and awareness. The disturbance develops acutely and it tends to fluctuate. And you must have at least one additional disturbance in cognition because there are multiple cognitive domains like memory, disorientation. The behavior must not better be explained by a pre-existing dementia. And most importantly, you should identify an underlying cause of their delirium. So the patient should have a medical condition, a substance intoxication, or withdrawal that causes them to have the delirium. If someone doesn't meet all 5 of these criteria, but they meet some of the criteria, that's when we label them as a subsyndromal delirium. And 67% of people on inpatient wards have subsyndromal delirium. So to diagnose delirium, I suggest using the CAM tool. This CAM tool has 4 features, and you have to have feature 1 and 2, along with either one of 3 or 4. And I memorized this using the mnemonic IADL. So I stands for inattention, and you can test for a patient's inattention using several methods, like a digit span, for example. This is helpful if they don't speak English. You can give them 5 numbers in their language to say forwards, and then 3 numbers for them to say backwards. Or you can do days of the week backwards or months of the year backwards. Patients can also be inattentive if they're just not paying attention during the interview, or they're easily distracted by other things in the room. The second feature is acute onset and fluctuating course. The third feature is disorganized thinking. So patients can have an illogical or tangential flow of ideas. They might answer your question with something that does not make sense or is irrelevant. And then the fourth feature is they have an altered level of consciousness. And some people think of altered LOC as reduced LOC, but patients can also have the opposite and be hyper alert, hyper vigilant, and easily startled. So this tool has a pretty good sensitivity and specificity of over 90% for diagnosing delirium. And to do a good delirium workup, you're pretty much doing a good medicine workup. You want a thorough review of medications, because meds like opiates, anticholinergics, sedatives, these can all precipitate delirium. You want to rule out infection. You can send studies for urinalysis, viral swabs, chest x-rays, etc. You want a good metabolic screen, especially electrolyte abnormalities like sodium and calcium, hypercalcemia causing delirium. And you want to check if people are just lacking their sensory aids, or maybe they change to an unfamiliar environment. But if it takes this little stimulus to trigger a delirium in someone, then it shows you that their brain is already very vulnerable and frail at baseline. You want to make sure they're not retaining. You can get an abdo x-ray to rule out fecal loading or post-void residual to make sure they're not retaining urine. And then, of course, structural causes can cause a delirium. So you can consider brain imaging or EEGs or cardiac workup. In terms of the pathophysiology of delirium, you can have multiple contributors, such as metabolic stress, drugs, and inflammation, that eventually lead to an imbalance in the neurotransmitters of the brain. But of all these neurotransmitters, acetylcholine is the most important one. So you can give anticholinergic drugs that reduce acetylcholine levels, even in healthy volunteers, and it can cause a delirium in them. So you can imagine what it would do to someone who's frail and older if you give them anticholinergic drugs. Whenever we see people with delirium in hospital, we identify through their med list what their anticholinergic burden is. And I personally use this website called acbcalc.com. It's free, you don't need an account. You just log in and you type in the name of a medication, and it'll give you a score from 0 to 3, 0 being not anticholinergic and 3 being the most anticholinergic. So as you can see, drugs like Benadryl and Gravol, they're highly anticholinergic. Amitriptyline is commonly prescribed for depression, pain, and sleep to outpatients. It's very anticholinergic, as is paroxetine for depression. Quetiapine we give very commonly to people in the hospital with behaviors, and it's quite anticholinergic. Even things like digoxin and loperamide are anticholinergic. So when I see people who have delirium, I try to either stop or gradually discontinue medications that are anticholinergic. Key point number 4 is to identify and prevent the administration of anticholinergic drugs that can exacerbate delirium. Many studies have shown that the pharmacologic prevention of delirium is not effective. So these are all drugs that have been tried that are not effective in preventing delirium, things like antipsychotics, cholinesterase inhibitors, gabapentin, ketamine, steroids, melatonin. These are not effective. And there's been some evidence for dexmedetomidine in the ICU and perioperative setting, but patients tended to have higher incidences of hypotension and bradycardia with dexmedetomidine. So from the literature, we know that antipsychotics don't prevent or alter the course of delirium, but sometimes we do need to give antipsychotics to people who are very behavioral or their behaviors are posing a safety risk. So these are the most common antipsychotics that I use in hospital to treat distressing behaviors of delirium. Haldol, for example, is very well studied. It's not that sedating. It does prolong the QT interval. So I actually don't use the IV version of Haldol at all because that's the one that's most associated with torsades. But Haldol does cause a lot of Parkinsonism, and it is a first-generation antipsychotic. I've been using loxapine more. It's a first-generation antipsychotic, but it doesn't prolong the QT interval, so I like it for that reason. And then quetiapine and olanzapine are good choices as well because they're quite sedating, with quetiapine being the best option if your patient has Parkinsonism. So here I just have a chart of some recommendations of antipsychotics you can use for your patients. So if your patient has no Parkinsonism and they have a normal QT interval, I tend to use the lowest doses possible. So I know quetiapine 6.25 seems really small, but it can be effective, especially in older, frail women. So quetiapine is a good option. Risperidone comes in a liquid formulation, so I like that for patients who refuse oral meds or they can't swallow well. Olanzapine I like because it comes in sublingual, oral, and then there's also an IM or IV option because I tend to like using a monotherapy. If I'm going to treat them with oral and IV, I like using the same one. And loxapine is a good option as well. If your patient is Parkinsonian, I actually use trazodone, which is not an antipsychotic, but it's sedating. But trazodone, it can cause sedation, orthostasis, which can increase the risk of falls. And trazodone can also cause constipation. The best antipsychotic for people with Parkinsonism is quetiapine because it causes the least EPS. If you really need an IV or IM option, I would just consult geriatrics or psychiatry because then you're getting into things like IV options that cause Parkinsonism. Or if you end up using IV benzos, then that could really worsen and prolong the delirium. And then lastly, if your patient has a prolonged QTC interval, I would just use loxapine. So even though there's not much evidence for pharmacologic delirium prevention, there's good evidence for non-pharm delirium prevention. And this program especially is an amazing program. It's called the Hospital Elder Life Program. And we had this in Hamilton when I was there as a resident. We're hoping to bring this to Scarborough Health Network. But this program was developed in 1993. And basically, if a patient's admitted to hospital and they're at risk for developing delirium, you just put in a health consult. The program has an elder life specialist and then trained high school volunteers that come visit the patient on a daily basis. And they help with things like reorientation, therapeutic visits, like they'll give them coloring books. They'll help put on their visual and hearing aids and help them drink fluids or eat their food. And this is associated with reduced delirium incidence. The number needed to treat is 12 to 16, which is a pretty great number needed to treat. If you compare that to using a DOAC and AFib for stroke prevention, that number needed to treat is over 100. The HELP program also reduced falls, and it's cost effective. So it saved $1,600 to $3,800 USD per patient. And then it saves money in long term too, $16,000 per year in the year following delirium. So I'm really hoping that we can bring this program to Scarborough Health Network in the next few years. And then consulting geriatrics has also been shown to reduce delirium, especially in the hip fracture or perioperative setting. Different hospitals have different ortho-geri pathways. So in Hamilton, if you had a hip fracture and you were over 65, you automatically got a geri consult. Also, getting hip surgery within 6 hours of diagnosis can reduce delirium. In the ICU, they use something called the ABCDEF bundle that helps reduce delirium. And this bundle includes 6 elements to help reduce pain, encourage spontaneous breathing trials, mobilizing early, engaging families. And this bundle reduced delirium incidence and duration, as well as hospital stay. They've even done studies on earplugs in the ICU, which has been shown to prevent delirium. And of course, mobilizing early helps prevent delirium. Key point number 5 is there's no effective treatment for delirium aside from addressing the underlying cause. So efforts should be focused on preventing delirium. In the second half of the presentation, I wanted to go over when to suspect a rapidly progressive dementia. And to do this, it's really important to delineate the timeline of cognitive changes. With delirium, we know that this starts off as acute onset from hours to days. Dementia is a more progressive and gradual onset disease that can present over years. And with a rapidly progressive dementia, these people present subacutely. Their cognitive symptoms start weeks to months prior. They can have motor, sensory, behavioral changes with seizures, myoclonus, and ataxia. And the definition of a rapidly progressive dementia, or RPD, is a dementia that develops within 12 months after the appearance of the first cognitive symptoms. So key point number 6 is if dementia develops within a year of the first cognitive symptoms, you have to rule out a rapidly progressive dementia. This diagram here was from the 5 largest case series of rapidly progressive dementia, and they identified 95% of the causes. As you can see, the most common cause of rapidly progressive dementia is CJD or prion disease. This is the prototypical rapidly progressive dementia. But these numbers might be overinflated because these were all suspected prion diseases that were referred to tertiary centers. The second most common cause of rapidly progressive dementia is neurodegenerative disease. And then in terms of the secondary causes, I've blown it up in this figure here. The secondary causes were treatable. 20% of them were potentially treatable of all RPD cases. And in terms of the treatable conditions, these are conditions like autoimmune diseases, vascular diseases, toxic metabolic encephalopathies, cancers, psychiatric causes, infections, and normal pressure hydrocephalus. So I'll go over some brief summaries of some causes of rapidly progressive dementias because I just want to make you more familiar with them. So diseases like CJD or prion disease, neurodegenerative diseases, autoimmune encephalitis, Hashimoto's encephalopathy, primary CNS vasculitis, and inflammatory cerebral amyloid angiopathy are very rare. So number 1, CJD is a prion disease, and 90 people in Canada were diagnosed with CJD in 2022, so it's very rare. The features of CJD are ataxia, myoclonus. They can get something called a startle reflex that's present in over 90% of people throughout the course of their illness. So you can either loudly clap or give in like a light touch to that's unexpected to the shoulders or limbs, and this can cause a startle in them. 20 to 40% of people can get cerebellar manifestations as the presenting symptoms. And then the end stages of CJD, they have akinetic mutism, spasticity, and myoclonus. The diagnosis of CJD does require CSF testing, so you can send CSF for 14-33 protein, which has a sensitivity of 85 to 90%. but the specificity is 80%, which is pretty low if you consider how low the disease prevalence is. A better test to send in the CSF is called the RT-QuIC. It's higher sensitivity and the specificity is 100%. The EEG will only show the classic periodic sharp wave and slow wave changes at the end stages of the disease, so it's not that sensitive. And then, of course, the MR brain is very important. So you can see here, you can get signal hyperintensities. This is called the cortical ribbon sign. You can see here in the right frontal lobe and the parietal occipital lobes. And the management of CJD is supportive. The median survival is only 4 to 6 months. If you want to manage the myoclonus, it may respond to benzos and antiepileptics. So this is a very important differential in rapidly progressive dementia. The second most common cause of rapidly progressive dementia is neurodegenerative disease. And typically we think of neurodegenerative disease as cognitive decline that starts years prior with gradual onset and gradual progression. But recent literature has shown that in these 3 neurodegenerative diseases, you can have rapidly progressive phenotypes. So for rapidly progressive Alzheimer's disease, this usually presents a bit earlier than your typical Alzheimer's disease at age 68 to 74. Typical Alzheimer's disease presents with short-term memory deficits, but in this rapidly progressive subtype, they have early executive and language dysfunction. These people also get atypical motor disturbances like myoclonus, abnormal gait, and seizures, and all of the patients died within 24 months of the disease onset. Dementia with Lewy bodies makes up 2 to 8% of rapidly progressive dementia diagnoses. The age of onset is 70 to 80 years old, and the prognosis is only 9 months to 4 years. So they have the same symptoms as regular people with DLB. They get fluctuations in the cognition, hallucinations, Parkinsonism, and they're very sensitive to antipsychotics. And then lastly, you can get tauopathies and frontal temporal lobe degenerative diseases that present rapidly. And these are usually the progressive supranuclear palsy phenotypes or the motor neuron disease phenotypes. So neurodegenerative disease is another important differential in rapidly progressive dementia. And among the treatable causes of rapidly progressive dementia, autoimmune encephalitis is important to consider. It is, again, quite rare with an incidence of 5 to 10 cases per 100,000 people. The presentation is a rapid development of confusion, working memory deficit, mood changes, and seizures that usually happen quite quickly within 6 weeks. For the investigations, you want to send paraneoplastic antibodies from both the serum and the CSF, because there are actually some antibodies that are more prevalent in the serum, like LGI1. But up to 50% of people with autoimmune encephalitis don't have antibody positivity. In the CSF, you can see a lymphocytic pleocytosis. Usually the white count ranges from 5 to 100. But again, in some cases of autoimmune encephalitis, they don't have lymphocytic pleocytosis. For example, like in LGI1, only 59% of them have lymphocytes. And you can get elevated IgG or oligoclonal bands. The MRI is important. As you can see here, you can see hyperintensities in the medial temporal lobes. So you should rule out infections that can mimic this, like HSV. And EEG can also show abnormal activity in the temporal lobes. The treatment for autoimmune encephalitis is immunosuppression. If they get seizures, seizure drugs are not that effective. You need to immunosuppress them with glucocorticoids, IVIG, and plasmapheresis. This is a table showing a list of antibodies that are implicated in autoimmune encephalitis. I've highlighted in red here, these antibodies are highly associated with cancer. And the most common cancers are small cell lung cancer and testicular seminoma, which is why when people present with rapidly progressive dementia, we often order CT chest abdo-pelvis to rule out malignancy. And these antibodies that are associated with cancer do not respond well to immunosuppression. They respond better with treatment with the underlying cancer. In blue, these are antibodies that are associated with limbic encephalitis, and they're less often associated with cancer. But when there is cancer, it's usually thymomas or lung cancers. And these antibodies in blue respond well to suppression, immunosuppression. So another important differential for rapidly progressive dementia is Hashimoto's encephalopathy. Because it's so responsive to treatment, they renamed it steroid responsive encephalopathy with autoimmune thyroiditis in 2006. Epidemiology here is quite rare, again, 2 cases per 100,000 people, presenting mostly in females 60 to 80. Usually their thyroid disease can be subclinical, and they can have encephalopathy, seizures, stroke-like episodes, hallucinations. The TSH here is usually normal, but you should be sending thyroid antibodies in the serum and in the CSF. Some people can have elevations in antithyroid peroxidase, only antithyroid globulin. Most people had both elevations. And the EEG is abnormal as well. So the treatment here is, again, it's steroid responsive. It's very good response to steroids. 91% of people, when you give them steroids, show a complete response. And so it's a diagnosis of exclusion. So measuring the response to steroids is important for the diagnosis. This is also a very rare consideration for rapidly progressive dementia. It's a primary CNS vasculitis, a vasculitis that's only limited to the central nervous system. And the incidence is 2.4 cases per 1 million person years, happens in both men and women. The median age is 50. The presentation is a sudden focal neurodeficit, symptoms suggestive of stroke or TIA, headaches, and cognitive decline. The investigations for primary CNS vasculitis are pretty low sensitivity, things like cerebral angiography, MRA, or CTA. The CSF can show a mildly increased white count or elevated protein. If you order a CRP or ESR, surprisingly, it's normal in most people because the vasculitis is confined to the CNS. And you can get a brain biopsy, but the sensitivity is low because the vasculitis can be irregular. And the treatment for this is pulse steroids with the prednisone taper, which induces a remission in 68 to 95% of people. So this responds quite well to steroids. It's important to note, though, that you can get a CNS vasculitis that's secondary to other conditions, like infections or autoimmune disorders, like lupus or Behçet's. And then the last rare cause of RPD that I'll talk about is inflammatory cerebral amyloid angiopathy. This is when people get inflammation against vascular amyloid beta deposits, and there's 2 subtypes. There's one called CAA-related inflammation, and there's one called amyloid beta-related angiitis. It's extremely rare, 0.13 cases per 100,000 people with an age of 67 years old. The presentation is a month of encephalopathy, behavioral symptoms, and headaches. For the investigations, your MRI is going to show patchy confluent white matter hyperintensities. You can get microbleeds, but the microbleeds are hard to catch on standard MRI sequences, so you do want to ask for specialized sequences like SWI and GRE. And 21% of people can have infarcts that are usually on the smaller side. And in the CSF, they can have elevated protein, absent bands, and the gold standard for diagnosis is a tissue biopsy. Treatment here is, again, steroids, pulse steroids, and then an oral steroid taper, and 58% of patients improve with steroid treatment. So to summarize the investigations for a rapidly progressive dementia, you want to do your basic core testing with serum screens for metabolic encephalopathies, tox screens, an MR brain with contrast, and you should be asking for special sequences to rule out microbleeds if that's within clinical suspicion. You can get an EEG, routine CSF analysis, but to the CSF, you do want to add CGD testing with 1433 or RT-QuIC. And you can add oligoclonal bands and IgG index for immune-mediated processes. For your paraneoplastic antibody panels, you should remember to send them from the serum and the CSF because some antibodies appear more in the CSF, in the serum. And you want to make sure that there are no infections causing their presentation, with some listed here. Other imaging you can consider are cerebral angiograms for vasculitises and then SPECT scans for neurodegenerative diseases. So key point number 7 is if a rapidly progressive dementia is suspected, you should involve neurology and geriatrics early since some cases are treatable. So conclusions from our talk today on delirium and RPD are that delirium is a medical emergency, and it is important to identify an attributable cause of delirium. Efforts should be focused on delirium prevention and to improve patient outcomes and reduce hospital costs. Consider a rapidly progressive dementia if dementia develops within 12 months of the first cognitive symptoms, since some causes of RPD are treatable. So thanks for listening, and I'm happy to take any questions. I see that someone named Grant asked if we monitor lipids when using loxapine or olanzapine. I don't monitor that in hospital. And even for long-term use, I tend to not monitor lipids when I use antipsychotics.
Grant here again. One more question. For patients who have been on long-term, of any medication that does have anticholinergic effect, and they've been stable on that dose for a long time for whatever indication, and then they come into hospital or as an outpatient, they start developing symptoms that you think are delirium. They're having delirium for whatever reason. You're doing their workup. If you don't find something that's clearly the cause or the trigger, so difficult to focus your treatment on that. Do you then start tapering off, or do you adjust that long-standing medication?
Yeah, it really depends on the case, but if I find there's a better substitute, I will give that as an option to the family. For example, I'll see patients that come in on paroxetine that's been used for their depression long term. If that's the only drug they've ever tried, I give that as an option to the family to try and cross taper them to something that is not as anticholinergic, like for example, sertraline or duloxetine or mirtazapine. But if, say, in the past they've had uncontrolled depression, they've tried many agents, and paroxetine is the only thing that works for them, I'm going to leave them on paroxetine.
That ACB website you mentioned, does it, apart from grading the different the level of anticholinergic effect of the drugs, does it have like an alternative? Like, say you input a drug that has a level 3 or like is pretty anticholinergic, does it suggest alternatives?
No, unfortunately, it doesn't.
Oh, okay.
Yeah. Yeah, that I use that website more for identifying drugs that are anticholinergic that could be contributing to the presentation, or just that increase that patient's anticholinergic burden from their med list. And then from that, I usually try and tailor a plan with the family to switch people over to drugs that are not anticholinergic. Yeah.
Thank you.
Hi, Tina. Can you hear me okay?
Yep, I can hear you.
So I think my screen says Ryan, but it's actually Alexis. So I stole Ryan's computer. Just kind of curious with respect to the rapidly progressive dementia, kind of, I guess, the iceberg phenomenon. Are you seeing most of these cases in hospital? Are they generally presenting to hospital? Or is there a subset of them that are seen in the community and completed their workup as an outpatient? I'm just curious what the proportion would be.
Of the rapidly progressive dementias I've seen, because our wait list at the GAIN clinic is so long, I haven't been seeing many in the clinic. Most of the cases of RPD I've seen are going to be an inpatient. When I have seen cases that are urgent in my clinic, I tend to refer them to Emerge, and I send them there so that they can get testing.
Got it. Thanks.
Yeah. Any other questions? Okay, it doesn't seem like there's any, so thanks for coming to today's talk.